This talk is on quite a niche area, quite a focused and rare area, but I hope one where you'll appreciate that actually there are some very interesting and exciting new developments coming along, and also that this is a really great example of a condition that needs a proper multidisciplinary approach. It definitely needs the transfusion side, haematology, fetal medicine, pediatrics, neonatology. There are so many aspects of this condition. So, fetal and neonatal alloimmune thrombocytopenia. So I don't have any conflicts of interest relevant to this talk. I hold several research grants, and unrelated to this talk, I have received speaker fees or advisory board fees from some pharmaceutical companies. So I thought I'd just go through is this is a rare condition. Even if you're in a really specialist centre, the chances are you're not going to see many cases a year. And so just talk over again what it is, what the investigations are, because that's really developing quite quickly. I'll do the case studies. I've cut down on the controversies because I know we've so we don't overrun. But the thing that's really big and different is this new treatment that's come in called neonatal FC receptor inhibitors. And I'll talk to you a bit about that in FNAIT and also just a little bit about the hemolytic disease of the newborn side, although I won't dwell on that. So what is FNAIT to begin with? Well, FNAIT is when a mum develops an alloantibody against a platelet antigen on her baby, on her fetus that's developing in the womb. And those antibodies can cross the placenta, binding to fetal platelets, and that can then lead on to fetal thrombocytopenia and fetal bleeding, particularly intracerebral hemorrhage. When I was at medical school, I was always taught that IgG crosses the placenta because it's really little and it can kind of wiggle its way across. But actually, that turns out to be nonsense. IgG crosses the placenta because it's actively transported through the neonatal FC receptor, more on which later. But you can imagine if you could block that, you could potentially prevent FNAIT. And there are all sorts of different antibodies that can cause this, but the most important one by far is anti-HPA-1a antibodies. And as I said, this is the platelet equivalent of hemolytic disease of the newborn. And FNAIT has a really wide clinical spectrum, ranging from the completely well baby on the left through to petechiae, bruising, and all the way through to intracerebral hemorrhage. And we know that if we were to check every newborn baby for FNAIT, then actually the incidence would be just under 1 in 1,000, whereas actually at the moment we're diagnosing about 1 in 10,000 babies with FNAIT. So we're missing lots and lots of cases. But what I don't know is whether actually we're just missing the very well babies on the left, or whether we're missing some in the middle, or whether actually we're missing some of the much more severe ones who've had poor outcomes. And perhaps unlike hemolytic disease of the newborn, FNAIT can affect a first pregnancy. And so there's no screening programme in the UK, at least at the moment. And so we don't necessarily pick this up if it's a first pregnancy. And Anthony Poles, pitched up there, is one of the NHS blood and transplant platelet immunology scientists from Bristol. And he's plotted out the number of NAIT cases that there have been over a sort of 15-year period and against the number of live births. And you might be able to appreciate how rare this is, that we're picking up what somewhere between about, the lowest is 40 there and the highest is 96 cases a year. So when you think about the number of centres across the country, we're picking, there are very small numbers of cases each. And so it's easy for there not to be expertise in different places. And if we look at that as an incidence rate, it's run at about 1 in 10,000, compared to that 1 in 1,100 that we might expect. And when a new baby is born with FNAIT, it can be absolutely anywhere. And this is once again Anthony's work, just plotting out all the new diagnoses of FNAIT over that sort of 13, 14-year period against which hospital they were born in. And whichever hospital you're from, you might appreciate where your dot is, with the size of the dot being the number of babies born there. But what I really want to just show from this is that it could really be anywhere in the country. And when it comes to FNAIT and what's happening, and this might be very familiar to some of you and new to others, the genetics of FNAIT are that all of us for our HPA type 1 either have an A type or a B type, and we've got 2 copies of the gene. The A type's more common, the B type's rarer. And so if a mum's going to form an anti-HPA-1A antibody, then she needs to be 1B, 1B, so she doesn't express any A. If she then has antibodies, then depending on her partner will depend on the risk to the baby. So if the father is 1A, 1A, then all the babies are going to inherit 1A from the dad and 1B from the mum. So they'll all be at risk of FNAIT. If the dad is heterozygous, so has 1A and 1B, whereas the mum's got 1Bs, then there'd be a 50-50 chance that the babies would be 1B, 1B, and so would not be at risk, or would inherit the 1A from their dad, and therefore be at risk. And last of all, if the dad's 1B like the mum, and that's the rarest type, it's about 2% of the population, then even if the mum has antibodies, then the baby won't be at risk. Now, you can't ask people to pick a different partner depending on their HPA type, and so we have to think about what we're going to do to manage future pregnancies. FNAIT is, I'd say, most commonly diagnosed by neonatologists or sometimes pediatricians. It can sometimes turn up actually on fetal scans, but usually what we're looking at is a thrombocytopenic baby who's generally otherwise quite well. There's all sorts of overlap with other conditions that can cause thrombocytopenia, certainly sepsis, torch viral infections, and of course, real prematurity can all lead to thrombocytopenia. And if you want to try and diagnose FNAIT, particularly in those where there's not another explanation, then the most important bits are checking the mother's blood and the baby's blood, although if you've got the dad as well, then that's very helpful. And the classic pattern is that the mum's 1B, 1B with anti-HPA-1A antibodies, the dad's often 1A, 1A, and then the baby's inherited 1A and 1B, and so is at risk, and that sort of proves the FNAIT. The 1A antibodies are by far the most important. They're about 85%. About 10% are 5B antibodies, and it's much more controversial how severe those are. Although I'd say at the moment in the UK we tend to treat both of them the same, and there are about 5% of other antibodies. And so certainly if FNAIT's still suspected, despite not having picked up an antibody, then it's important that we do a cross-match between the mum and the dad's blood to see if there's some kind of reaction, because sometimes it turns up rare antibody types. So just give you an example now of a case that was actually diagnosed during pregnancy. All of these are based on reality, but have just been adjusted a little bit for patient confidentiality. And so this patient was actually in her second pregnancy. Pregnancy had been going completely normally, not aware of any problems herself. But then at around 31 weeks gestation, she stopped being able to feel her baby moving. And an ultrasound of the baby showed the images that are on the right. I'm sure even for those of us who are not experts at looking at ultrasound, might be able to appreciate that that's the baby's brain we're looking at there, the two hemispheres of the brain, and one of them's almost completely full of blood. And unfortunately, this was not a survivable hemorrhage for the baby in the end. The fetal medicine specialists were able to pass in a needle to sample the cord blood and showed that the baby had a platelet count of 7. And they were also able to get a small sample for HPA typing. And when that came back, it showed that the samples from the mum, the dad, and the baby showed the pattern we might expect of the mum having 1B, 1B with anti-HPA-1A antibodies, and the baby being 1A, 1B, which just shows that the baby's at risk. So that would confirm FNAIT, and certainly on the more severe side. In this case, the dad is 1A, 1B, which would mean that there'd be a 50-50 chance of future pregnancies being affected. So I'm going to talk quite a bit about antenatal management. We will move on to the pediatric side afterwards. I'd say the most important bit, this is the most important slide of the whole talk, is that women must be counselled about the risks of future pregnancies. And I'd say one of the big challenges with FNAIT is that there are so many different specialties involved that care can end up being a bit broken up. And so particularly, there's quite a high risk of mums having a recurrence in the next pregnancy. And so it's really important that mums get counselled. Certainly in the Thames Valley, I see all these ladies, and I try and see them at 3 months after delivery, so we can talk about the next pregnancy. In other hospitals around the country, it's done by fetal medicine, sometimes fetal medicine and haematology jointly. But it's really important that we do this, the most important thing of this talk. We talked through the previous pregnancy. We've got to be careful about making assumptions about paternity, when it comes to the next pregnancy and the risk. We talk through how someone might be treated in the future pregnancy, and then we'll give them patient information. And this is the NHS blood and transplant platelet antibodies patient information leaflet. So if we go to that first case again, it's always important to go back over the diagnosis, make sure it's correct, check if the father's the same, and need fetal medicine involvement really early in this pregnancy. In this case, we know that the dad was heterozygous for 1A, 1B, and so the baby's got a 50% chance of being at risk themselves. Now, treatment is quite burdensome, it's quite expensive, and if it can be avoided, it's worth trying to get the diagnosis right. The best way of doing this is likely to be free fetal DNA testing. And as you may all know, that's available for when you're checking, for instance, the RHD type for women when we think about hemolytic disease of the newborn. At the moment, free fetal DNA testing isn't clinically available in the UK, although there is a laboratory in Sanquin in the Netherlands where we'll sometimes send samples. But the free fetal DNA testing in the UK is in development. And certainly for my last few pregnant patients, I'm now able to send samples to NHSBT in Bristol for them to try and validate their assay to make sure that it's giving accurate results. If you can't get free fetal DNA, then the slightly more old-fashioned way of doing this with amniocentesis can be used to confirm the fetal HPA type. But the problem with these invasive tests is the small risk of inducing miscarriage. So if we can have a free fetal DNA test, that would be better. And I hope we will in the near future. And then it comes to, well, if we're going to treat at the next pregnancy, then how high is the risk to the for the baby in a subsequent pregnancy? And the most important risk factors that we know about at the moment are what happened in the previous pregnancy. And so what we perhaps call a standard risk pregnancy now is one where the baby had thrombocytopenia or bruising, for instance, and a low platelet count, but no major bleeding. And if that's the case, then there's about a 7% chance, or up to, it may be a bit lower in some series, that the next pregnancy may be a baby with an intracerebral hemorrhage. Whereas if a previous pregnancy, the baby had an intracerebral hemorrhage or died, then the risk is very high that the next pregnancy there will also be an intracerebral hemorrhage. So that risk profile is important. And it's particularly important because we can do something about it. And so giving intravenous immunoglobulin once a week is really good at cutting down that risk. And for those high-risk patients, we'd start at 12 weeks, and for the standard risk ones, usually at 20 weeks. And the risk of intracerebral hemorrhage then is low, but it's definitely not zero. And I can remember when I started doing haematology, going up with Professor Murphy with the intrauterine platelets quite often to see the fetal medicine team infusing those for FNAIT, whereas actually now it's really very rarely used because medical management's so much better. NHS England recommends the following dosing, and I'm conscious that you're paediatricians and neonatologists mainly rather than fetal medicine teams, so I won't dwell on this a lot, but generally you can start at a slightly lower dose for the standard risk patients and a higher dose for those who are at high risk. But despite intravenous immunoglobulin being good, babies are still born with a platelet count less than 30. And so these are 3 studies showing the different IVIG dosing regimens that were used, 0.5 gram per kilo on the left, 1 gram per kilo on the right. And actually, despite intravenous immunoglobulin, somewhere between 8 and 16% of babies have still got a platelet count less than 30. And in fact, we've very recently had a patient who was on a good dose of IVIG, but still had a baby with an intracerebral bleed despite IVIG. And in the UK, when we sort of survey practice, this is Asha Agarwal at the top, who's one of my clinical fellows. We've got fair consistency about what we do by and large for these patients. Almost all of our standard risk patients, those that haven't had bleeding, are getting IVIG once a week. They're not getting steroids, and most of them are getting 1 gram per kilo. Although I think perhaps 0.5 gram per kilo would be okay. We've got a bit of variation when we're starting the IVIG. And we're generally pretty good with those high-risk patients of making sure they get a higher dose of treatment. The time when we really need everyone involved is when it comes to the delivery plan. And we've had 4 deliveries in the last few weeks, and we've got another 3 coming up. And in each case, we have a laboratory scientist, hematology consultant, fetal medicine consultant, neonatology consultant, and pediatric hematology consultant, all involved in making the plan. For the mum, we try and make sure that there are HPA-1a negative red cells available in case of her developing post-transfusion purpura. Although if they're not, she gets standard red cells, and we can deal with that if that ever happens. It's so rare, I've not seen it. Generally trying to deliver earlier than term, and at 37 weeks it's kind of considered the best balance between the baby having been sufficiently developed, but also trying to minimize ongoing antibody exposure and try and reduce the baby's exposure to things that might increase the risk of bleeding. For the baby, we need really early neonatal involvement. We do our best to try and check the cord counts and cord HPA type, but I'm sure you will all have lots of experience of this, but in my experience, if that's frequently clotted or there's an issue with it, and when that's the case, you then have to go on and take a sample from the baby. We will always try and make sure that there are HPA-1a negative platelets available for the baby, although once again they can have unselected if that's not available. And for a recent baby who was born where we knew that they were affected by FNAIT and had intracerebral hemorrhage, we just gave platelets straight away without waiting for the platelet count. And we were glad we did, because it took a long time to get the platelet count back. They'll get a cranial ultrasound to check for bleeding, and because of the risk of bleeding into the muscle, they delay the intramuscular vitamin K till a bit later. Now, Anne's gone into much more detail about platelet transfusion thresholds, and I'm not a paediatrician or a neonatologist, but based on those data from the Planet 2 trial, by and large, we're aiming for that platelet count of 25 or more now for management of newborns with FNAIT, and we'll usually aim for a slightly higher count if they've actually got active major bleeding. The old FNAIT guidelines, which are currently being revised, had recommended a threshold of 50 with 100 if there was bleeding. I think I think the movement internationally now is to slightly more restrictive transfusion thresholds. And by and large, actually, platelet transfusions are the mainstay of FNAIT treatment, but NHS England does allow IVIG if there's an ongoing transfusion requirement. And just to give you a sense of the sort of clinical course that we kind of get with neonates with FNAIT, this is days after delivery along the x-axis, platelet count along the y-axis, and often they'll start very low. I'd say they generally respond very well to platelet transfusion, but you can see in this case there was a sort of spike after the transfusion. The maternal antibodies were still present, and so the platelet count then started to dip. And then somewhere around the sort of the second week, as the maternal antibodies were cleared, the baby's platelet count just normalized again. There's quite a bit of variation between babies and how long they take to recover. But I suppose what we really want to avoid is cases like this, where we're called about a woman in her second pregnancy at 40 weeks gestation. Actually, looking at her notes, it said in her previous pregnancy, she'd been diagnosed with a baby with FNAIT who had a poor encephalic cyst, the sign of intracerebral hemorrhage. And she'd been seen by the baby had been seen by a paediatrician, and it was recorded in the baby's notes that the FNAIT had resolved, which of course it had for the baby. But then the mum wasn't counselled about the risk for future pregnancies, and it meant that then at 40 weeks she then had another baby with a poor encephalic cyst. And so I think these are the ones where I was just trying to emphasize before about the importance of counselling when these are picked up, but I think this is absolutely essential. And there's a wonderful patient support group called NATE Babies, and they're based in the UK, but I think as the only kind of international group, they've ended up being the sort of go-to people across the world. I would say they're incredibly knowledgeable about FNAIT. So new developments. One of the things I've started to become conscious of is just how many variations there are on the presentations with FNAIT or challenges with treatment. And so we've pulled together a national FNAIT group, which has representatives from most regions in the country, and you've got fetal medicine specialists, paediatricians, neonatologists, laboratory specialists, so that we can then have a way of discussing some of these difficult cases. And we had our sort of first face-to-face meeting in Oxford last year. A company called Rally Bio was trying to set up a sort of screening program followed by giving preventative anti-HPA-1a antibodies, and their preliminary data was very promising, but they'd only dosed one pregnant woman and they weren't getting good pharmacokinetics, and so that trial's been stopped. So we don't have further data there. But what is being developed now, and what is quite exciting for these fetal maternal conditions, are neonatal FC receptor inhibitors. I think this is what I'm just going to focus the last few minutes of my talk on. So why talk about them? Well, actually, these trials are open at the moment. It's very unusual, I think, for a pharmaceutical company to be doing trials for a novel agent in pregnancy. What's really important here is they can block those antibodies from crossing the placenta. And this could work for FNAIT, but also for all sorts of other conditions where antibodies cross the placenta, including hemolytic disease of the newborn. And they work in two different ways. We've also got trials in adults with autoimmune conditions, because if you inhibit neonatal FC receptors, they sit on macrophages, and this reduces the level of IgG in the circulation. So, for instance, in myasthenia gravis, in autoimmune hemolytic anemia, these drugs are being trialed to try and treat those autoimmune diseases. But also they've got this important factor here that they can block IgG from crossing the placenta. And so if you've got a harmful condition where IgG is crossing the placenta and harming the baby, you can block that effect. And this is my hand-drawn way of doing it. So if you imagine the maternal bloods at the top and the fetal bloods at the bottom, you've got the placenta with the neonatal FC receptors in the placenta. And the baby's platelets here have got an anti-HPA-1a genotype and phenotype, and the mum's got an anti-HPA-1a antibody. That will actively be transported across the neonatal FC receptor. It's not just slipping through because it's small, it's because it's actively transported. That can then bind to the baby's HPA-1a, and that then leads on to the fetal platelet destruction. Whereas if we give nipocalimab and we block those receptors, then the IgG might well still be there in the maternal circulation, but the platelets are then left intact. Now, I'm just going to pivot now to hemolytic disease of the newborn very briefly. And the reason I'm doing that is that this, I think fantastic trial from last year has been published already, looking at women who had really, really severe hemolytic disease of the newborn, where they were losing babies at a very early stage despite intrauterine transfusion. And all of them were given nipocalimab. Just so the severity of it's shown there on the right. You might appreciate that actually in their qualifying pregnancy, that's the pregnancy before they went into the trial, only about a third had had a live birth, so 2/3 had had a baby that had died. The gestational age at delivery was only about 23, 24 weeks, and fetal high drops from very severe anemia was there in about half of cases. So in order to go into this trial, they needed to be pregnant again. They had to have that history of hemolytic disease of the newborn, and they had to have the proven red cell antibodies. And they were all given weekly nipocalimab. And the way these results were presented is that on the left is their first pregnancy, and the numbers down the y-axis are the different individual pregnancies. And then the length of the bar is how far the pregnancy went along, with a cross at the end being a fetal death, and a diamond being an intrauterine platelet transfusion, an intrauterine red cell transfusion. And you might well be able to appreciate that these pregnancies were not going on for very long. There were lots of fetal deaths, and there were lots of intrauterine red cell transfusions. Whereas for those that were given nipocalimab, which is the second part, all the patients in the trial, then almost all of these were going much, much further through pregnancy, and many didn't need intrauterine red cell transfusions at all. There was one death in the baby, and that was from complications of an intrauterine transfusion rather than the medication. And the outcomes were very much better. The number of live births that had carried to 32 weeks or more absolutely shot up. The number that had high drops was now 0, whereas it had been more than half in the previous pregnancy. And the number of intrauterine transfusions went right down. So it's really encouraging. I guess the worry is going to be that you block the IgG that's harmful, but you may well be blocking the for better word, good IgG, the IgG that protects the babies. And of the 10 babies where they had IgG levels, 60% of them had a low IgG at birth, and they were given IVIG if their IgG levels were intravenous immunoglobulin if their IgG levels were low. But none of the babies had unusual infections, just had normal childhood illnesses afterwards. And this trial has given us lots of reassurance about then using these medicines in pregnancy. There is a trial underway in hemolytic disease of the newborn, which once again is not the focus of this trial, but it's a sort of randomized trial of nipocalimab or placebo for hemolytic disease of the newborn. So it's like the next stage. And I know this is a sort of Yorkshire meeting, and Leeds is one of the centres for that study, but the others are down there at the bottom. But thinking about the effectiveness there of nipocalimab and then moving on to FNAIT, there are then 2 trials that are running for FNAIT. There are different approaches around the world in how FNAIT's managed at the moment in pregnancy. In some countries, like in Norway, they've got a very sort of hands-off approach, particularly for standard risk pregnancies. They'll often not give IVIG. And so there's one trial which is just comparing the nipocalimab to placebo. The one that we're running in the UK, because we tend to give IVIG, is comparing nipocalimab with IVIG. And we've recruited the only 2 patients in the UK so far into that trial in Oxford. One of them has delivered her baby. And while lots of the results of this trial are confidential, I am allowed to say that the baby was born with a completely normal platelet count that was given nipocalimab. We're really keen to recruit more patients for this. I think it's a really good way of saving transfusions for these babies. If they've got an antibody in a pregnancy that was affected by FNAIT, they can go into the study. The study will pay for their transport, hotel costs, and so on for them to travel to the site. It's a 4-to-1 randomization between nipocalimab and IVIG. And once again, the UK sites are down here. Once again, if you're based in Yorkshire, it might be Birmingham or Liverpool would be your closest centres. We're very happy to see anyone in Oxford. So in summary then, I think it's really important that babies born with thrombocytopenia or intracerebral hemorrhage are considered for FNAIT. And I think the key bit here is about referring mums for counselling early. IVIG is good for reducing the risk of intracerebral hemorrhage, but really I think it'd be great to get as many patients in the country as possible into the Freesia 3 trial to test out nipocalimab. And if you've got difficult cases, please do email me, and I'm really happy to put things to the national group. Thanks very much, and I'll stop my talk there.